Good afternoon, everybody. My name is Ashish K, and I'm the Dean of the School of Public Health here at Brown and Professor of Health Services, Policy and Practice. And this is a continuation of our series, Conversations with the Dean, that we started last August with our inaugural conversation speaker, Dr. Tony Fauci. And we continue in the tradition of great public health and scientific scholars and leaders today with someone I have known well for many years, Gökhan Hotamışlıgil. Professor Hotamışlıgil is the James Simmons Professor and chair of, head of the Sabri Ülker Center at Harvard T.H School of Public Health, and has many, many accolades to his name. He really is one of the preeminent physician scientists in the country and has won many national and international awards. And curiously, Gökhan is a professor whose work has sat at a public health school. And I say curiously because so much of the kind of work that he has engaged in and led in many places would be at a medical school. And that is really the basis of our conversation today, because when we think about public health, we have a bit of a mental model of public health is the public part of this. It's out in the community. And it is very much those things, of course. And we believe deeply in that. And yet, Gökhan has been one of the few scholars I can think of who has really thought about the role of what happens in the lab, what happens at the bench, and its implications for global public health. And so there really was no one better to invite to this discussion than Professor Hotamışlıgil. So Gökhan, thank you for being here. And the goal here is we're gonna have a conversation that I have a bunch of questions, but I'll also be monitoring the chat and Q&A sections, and we'll get to the ones that are in there by 12:30, 12:45, so in about half an hour, 40 minutes. But I will be monitoring them, and if interesting stuff comes up along the way, I'll try to squeeze them in. But Gökhan, let me start in some very basic ways by having you tell us a little bit about yourself. And you've had this very famous career, and yet you started off, you started off as a physician, training at Ankara University, and then got your PhD here at Harvard, or not here, but here in the United States at Harvard. What is that? Tell me a little bit about tell us a bit about that journey, starting off as a physician, really shifting to becoming a scientist, and how you see the intersection between being a physician and scientist in your career, and how has that shaped the work you do? So just broadly, if you could give us a bit of that background, that'd be really helpful to get us started. And you're muted. So.
Yes. Yeah, thank you, Ashish. It's really a great pleasure for me to have this conversation with you. And of course, this is as close as I will get to Dr. Fauci in terms of the hierarchy of accomplishments, but it's very generous of you. And also, I mean, let me start by your signature opening, saying, hi, Ashish, good to see you. Thank you for having me on. Yeah, so actually, I think you ask an interesting question. In many ways, maybe the way I made this transition, actually, it reminds me of the identity issues between public health and medicine, perhaps somewhere in between basic science. Because, I mean, I grew up in rural Turkey, where my father was a physician. And so that's really where most of my initial perception of, medicine, dealing with human life, dealing with infectious disease. Of course, at a time where tuberculosis and malaria was a huge, huge problem in those areas. And really, my mind was shaped by very heavy dominance of medicine. So for my father, for example, I mean, medicine was the king. And basic science were only for those who are not so good in medicine. So that was the really classic culture that I grew up with. And then really, that occupied all my youth. And then I went to medical school and graduated from medical school, started my residency in pediatrics. And at the last year of it, there was an opportunity to come to States just to complete our residency. There was a program that we could use. It was fully funded, both for me and my wife. So we essentially came here to complete our clinical training and go back and continue on that clinical track. And we really, neither of us, particularly me, I didn't have science in mind, or I didn't have public health in mind. So all of those pieces really come together here in the States at my time at Harvard.
So what led you down the path? And I'm going to get into the substance of this in a minute, but I want to start just by fleshing out. So here you are, you're here for residency. The mental model is medicine is, to use your words, medicine is king. Medicine is sort of triumphant, more important than basic science, public health. And yet you decided to go get a PhD and train and put a lot of time and effort and years into learning a whole set of new skills when you already had the most important skill of all, which was to be a physician. Yes. I'm not saying it is the most important skill. I'm saying that was the mindset. And that's a mindset, by the way, that's pervasive in many parts of the world, right? And so it's not an unusual mindset. Mm-hmm. What leads you down that path?
Yeah, I mean, part of that may be, of course, when I think back, part of that may be what was in my DNA. Because, hanging around with my father was really adamant in fighting with tuberculosis. So he had this mobile tuberculosis screening station that he drew all around the rural Turkey, taking x-rays, doing sputum smears, and pus staining to detect TB positive distributed medicine. So that, I mean, in essence, that is really description of public health at a time that, I mean, public health was not really in the radar screen. But then I think we also really were astonished by what was happening in medicine and biology and genetics, especially in the mature years of my medical school training, and where I didn't really have exposure to that. Neither had I any exposure to an organized operation of public health. So those things, actually, I got exposed to both when I was doing my training here. And I actually, of course, this is just my personal perspective. I thought the combination of these really were the most powerful. So you could, why not to take advantage of what you learn from medicine and bringing health services to people and healing to people, then to intersect that with why and how these illnesses are occurring at the molecular and cellular level, and then which could, of course, amplify your impact, if even with a small degree of success. And then, I mean, think about combining it with a broad spectrum as public health. And this is actually, I have to admit that this was not really part of my vision. I just learned this along the way. So first, the impact of science, and then actually later, maybe the last chapter is to really get excited about putting it in public health framework.
So the reason I obsess on this, and I start with like pushing you a little bit on this, is, a lot of people who are listening to this and will be listening to it are students. And when you are a student, when you're a trainee, there's a path. There's a path that you're aware of. You get your master's, maybe you get your PhD, you do a postdoc, you become an assistant professor. And what you see is that every once in a while, you look at people who were on a path, who then decided to either jump to or incorporate an adjacent path. This idea of the physician who then gets a PhD to get training in molecular and cellular biology is not actually a natural. I mean, you already were a physician. Why would you even need that? But the point is that the most important new areas of discovery, new fields get created when this kind of bridging happens. And in retrospect, that bridging looks totally obvious. Of course you did that. Lots of people, I assume, but actually it wasn't really that commonplace. And it's my way of actually encouraging people who are listening. You will find moments in your career where the path is very straightforward and there's an adjacent path, and you can see how combining or jumping or integrating will actually open up a new field. And it's people like Gökhan who did that. That gets us into new areas that are really exciting. And I want to talk about those new areas that are really exciting. And I want to get to the substance of it at this moment. So I'm going to come back in a little bit to talk about the COVID pandemic, partly because I spent all my day talking about the COVID pandemic. So if I can spend like 20 minutes talking about something else, I want to do that. But before the pandemic, if you and I were having this conversation 2 years ago, we would have brought up the fact that there is a different kind of global epidemic, and that is disorders, metabolic disorders, and sounds kind of technical, but it shows up in all sorts of ways, whether it's diabetes, cardiovascular disease. There's a whole bunch of manifestations that end up being very, very profound from a societal point of view. Tell me about your interest in that. How did you get involved in working on that? And why that's a public health issue? Now, of course, diabetes is a public health issue, cardiovascular disease is a public health issue, but it seems to me like studying the underlying molecular and cellular mechanisms, is that a public health approach? So first, let's talk about the phenomenon, your interest, and then how you feel like the science of it is important.
Mm-hmm. Yeah. I mean, as you say, Ashish, this was, at least in my view, was the greatest really threat to global public health. And actually, this might sound a little bit obnoxious and controversial, but it still is the greatest risk to global public health. And I mean, if you just break it by numbers, only diabetes kills 5 million people every year around the world. And of course, this is, I mean, many multiples of, for example, the death toll from many infectious diseases, HIV, malaria, tuberculosis, and so on combined. And so, of course, the issue is the urgency, because when you face a pandemic like COVID-19, the urgency, of course, really brings it to the forefront. Whereas in chronic metabolic diseases, and these things usually come as a cluster, the time frame is very long. And in general, I think when time frame is long, people have difficulty in comprehending the scale of the threat individually, and then, of course, institutionally and policy-wise. So this is one component. And perhaps the other component, which also drew me into this field, is it is very complex. And there are really no easy solutions. And there are many reasons for that. Of course, this is evolutionarily the most fundamental process in human body. And before everything, before two molecules came together, you needed to have some sort of a metabolic flux arrangement. So it is as old as life or biochemistry on Earth.
Okay, so I'm going to interrupt you for a second to say it's complex, but the simplistic part of my brain says, okay, so we have metabolic disorders, but isn't there a relatively simple solution to all of this, which is people should just lose weight, that we should have less obesity? And is it more complicated than that? Or, I mean, of course, weight loss itself is hugely challenging and difficult, but or do you see the work you're doing as broader and more fundamental?
Yeah, I mean, the short answer is, of course, obesity is a big risk factor for all of these chronic metabolic problems, but it is not the only risk factor. For example, age is the other big risk factor. And for example, cardiovascular disease, while obesity is a risk factor, there's plenty of it which is not really dependent on obesity or just cannot be resolved by weight loss. So there is a huge component, of course, that is driven by obesity. And you're right. I mean, if we had found a solution for obesity, then that will make a huge impact on the incidence of metabolic disease around the world. But it will not solve, at least in my view, it will not solve the whole problem. And of course, this is maybe a really great transition, really, to ask our record. So how did we do, for example? So we knew that this is happening for 50 years at the very least, and the success story is not there. I mean, the grades are not are not very good all around the world. We were not able to control diabetes. There's not a single geography where incidence of diabetes has dropped, and same things could be put forward for cardiovascular disease and so on. Mortality is decreasing, of course, due to cardiovascular disease or cancer, but this is not really at the prevention end. It's more on the availability of new treatments and medical care.
That's a really important point, that if you look at it from a population health point of view, it's still cardiovascular disease, diabetes, but things that have a metabolic disorder at their heart, not only are some of the biggest killers of people and biggest sources of disability, but the progress on it has been really in the area of treatment after the disease has already been created, right? So the aspirins and the beta blockers and the ACE inhibitors and the cholesterol medicines, et cetera, all of which are terrific, but it's really in the realm of medicine that so much of that has been. And again, we can talk about that fine line between medicine and public health, but these are huge public health issues. So how do we begin to think about prevention of metabolic disorders, and what does science have to tell us about that?
Well, I mean, this is a very critical point. Maybe this is really the framework of the topic of our conversation. So I think, if something is not working, so the prevailing framework has not really produced the desired results, I think that really it calls for a questioning of this approach. And the main pillars of that approach. Of course, I don't pretend to know the answers to this, or run a criticism of the public health in the past 50 years. But in this particular context, I think we must first ask this question. And because the past 50 years also has been an enormously exciting period for biomedical sciences and basic sciences. I mean, many revolutions took place, from Human Genome Project to genome editing technologies to stem cell based, so we can understand the origin of tissues, cells, organs, how they function, how they change their program based on what they are exposed from the environment. And so while all of these are taking place, I would ask daringly that a similar transformational movement has not really quite appeared in the area of public health. And so with the scale of, for example, genome editing or genome biology in general, so many, of course, important things happened. And so the question is, while something so relevant and so dramatic is happening at one hand, can we and shall we seek for ways to really empower also public health with this enormous capacity? And if so, the answer may be yes or no. I don't really pretend that I know the answer, but if it is yes or maybe, then I think it will be very exciting to search for models to do it.
So I have both a bit of a bone to pick with you, or an area of gentle disagreement. I don't know about gentle disagreement, actually. It may not even be a disagreement. So what I'm hearing you say, which is, I think, provocative, certainly, and you may in fact be quite right about this, is what is the public health equivalent of the Human Genome Project? What is the public health equivalent of, of CRISPR-Cas9, right? And one could make the case that the huge gains of public health were in the first half of the 20th century, right? The sanitation, the improvements in food safety, yes, there were other, and obviously public health has continued working, but maybe in some of the bigger challenges, we've not had that massive breakthrough that maybe we've been working, we've made modest progress, but not the transformational. A, is that your point? And B, if that is your point, then how do we begin to change that?
Yeah, it's kind of my point. I can give this example. I mean, sometimes when there is a big success story, that can, of course, be a huge motivation for people and a real great stimulus for the field. And I mean, we talked about diabetes. Let's talk about insulin. And this year is insulin's 100-year anniversary, discovery of insulin. And it was a huge discovery. I mean, think about this. Children were dying in the hands of their mother. There was nothing to do except for counting the days. And then suddenly a solution is injected to these kids and they become normal. It's almost like a miracle. And it is such a huge impact, for example, that some people will argue, and I will refer to, for example, the late Roger Unger, that sometimes a huge success story can actually suffocate the rest of the field. For example, pancreas did not only make insulin, and insulin did not only regulate glucose, but I mean, I can increase these examples, but this dominant piece landed upon us. And it took 100 years maybe for us to recognize and really put the necessary emphasis on other things related to insulin. And maybe I don't know, the equivalent of insulin in the public health was the John Snow story, or the Broad Street pump.
Yeah.
This is so enormous. Think about the magnitude of the problem, the cholera epidemic in London, and then with clever calculations and detective work almost at the field, you can have a major impact. So in some ways, I don't know, this may not be the best example, but to me, it feels like the insulin moment for public health. And sometimes that kind of success can also put such a strong framework on the practitioners and people who think about the future of a certain discipline. It might be difficult to expand and go into new avenues, a little bit more experimental systems and so on. It's not only really related to the minds of people who are involved in public health. It's same for accreditation institutions. It's same for curriculum activities. Some of the obligations that also determine this framework. And
yeah. So let me say, let's talk about the insulin moment, because that's actually a very interesting idea. And the idea is it's something so incredibly powerful and so incredibly transformational that, as you said, that it sort of suffocates all the other sort of science around it, because you sort of have the solution. There is more than a little bit of a risk of that in this pandemic. Mm-hmm. And I want to come back to this, talking about this pandemic. So there are lots of ways of seeing what happens next in the months ahead. But let's be honest that the thing that will affect what societies feel like on September 1st of this year, which societies are doing well and which societies are struggling, is vaccines. Countries that have broadly vaccinated their populations will have some semblance of normal. And countries that have not will be in the throes of potentially very, very difficult situations. And the mental mindset that is going to almost inevitably come out of this pandemic is that pandemics are solved by vaccines. Mm-hmm. I'm a huge vaccine fan, right? Like, I'm out there every day going, get vaccinated. So I'm not the guy who's going to tell you that that's a problem. But it worries me that it's a little bit of a problem, that it's the mRNA vaccine particularly, but the others too, is a little bit like the insulin here. And I'm worried that we will miss an opportunity to look more broadly and think more broadly about how societies manage pandemics. What else helps? Are you worried about that? Does that feel like a similar situation to you?
Yeah, I mean, that's a great point, Ashish. And of course it is. I mean, this, especially during the course of this pandemic, it is an incident moment. And I mean, having said that, I completely agree with you on this one, that as excited as I am and as a big advocate of the power of vaccination as I am, yeah, I do worry that this will kind of replace the meaning of, public health or prevention. There are, of course, things that we should really learn from this, because in one hand, it really demonstrates the power of science, really. And it is the power of science that can deliver you the most incredible tool. It's so exciting. But on the other hand, I mean, there are so many more things that needs to be done for this to really generate the impact that public health really aspires to. And from equity to health systems to global cooperations and so on. So of course it is not the only story, but it's a great example, because why public health, of course, need to embrace and does embrace vaccination. I mean, vaccination is the product of science, and if that can set up a framework for us with the similar scientific path, we can gather more tools in our hand to implement public health. Why to shy away from these tools? So I don't really believe in public health uses these tools and medicine uses these tools and biotechnology uses that tools. Why not use all the tools? And it's almost silly to draw these boundaries between disciplines, between even schools. I mean, so this is really time. I mean, if you ask me, like one of my thoughts is that this is, for example, a time to really the dean of the School of Public Health and dean of the medical school to be really, I mean, partners in crime in every aspect, from education to educational programs to applications, research, infrastructure, etc. So why not use all the tools?
Yeah, yeah. I was going to go down a slightly different path, but I see a question come in that actually really leads well with the question you raised. And the question that was asked, let me just pull it back up here. It was a question that says, as scientists, how can we contribute to the equal spread of knowledge and technologies to all of humanity? For example, we have great technologies for glucose management and diabetes, but they're not available and affordable. And actually, it's a really nice example because you started with insulin. So yes, insulin showed up 100 years ago and transformed diabetes, type 1 diabetes in children. There's still parts of India, for instance, the rural villages of India where I actually grew up, where the idea that a 5-year-old would be able to get insulin on a regular basis and that it would be pure and it would be reliable is not there. And so we still have young children who have type 1 diabetes who die essentially for a lack of insulin. That's 100 years after insulin showed up. Yeah. And so, we talk about vaccine inequity a lot, and we should be talking about it even more. But it's a reminder that these things are not one-off random things, that the inequitable distribution of this technology is a deep public health problem. So how do you, as a scientist looking at these great scientific discoveries like the mRNA vaccine or like insulin from 100 years ago, see the obligation of public health to ensure that it is widely available to everybody and not just to the select few?
Yeah, I'm full-heartedly believing in this. I mean, the mother of all problems as exposed during this pandemic is inequity. And inequity in information distribution, inequity in service distribution, tool distribution, health opportunity, I mean, you name it. And so this is very central to of course, to the mission of public health. So just generating the scientific advance is not really the solution to all of the problems. There are many problems that we should have solved by now. But I will say two things. On the information end, Ashish, this is not a new problem. If you go 500 years, before insulin, to Copernicus, it took 500 years for people to accept that the world is round. And even at this age, there are people who don't believe in that. And some of these people are very prominent people. And so sometimes, this information distribution is a historical challenge, and it will continue. And this is actually also, if we have time, we can come back to this. This is an area where public health actually needs a revolution as well. We cannot follow the same kind of tools and vehicles that we have been using to disseminate knowledge. And you know this better than anybody, because you have been disseminating tremendous amount of knowledge for the entire period of the pandemic. The second of the tools, and again, this is a very complex issue. We cannot fit this into maybe this short conversation. But one thing I would say is perhaps one element of this is public health as an enterprise really needs to build perhaps closer links and channels with industry. And we really haven't, until maybe quite recently, we have not been able to develop a public health industry. So public health, and we have to accept reality. I'm not a great fan of capitalism, but this is the reality that we live in.
And why do we have to develop a closer tie with industry? Because that does make a lot of people in public health kind of sit back and say, I'm not sure that's such a good idea.
Yes, I understand that. But this is because if public health disciplines can help develop new models of distribution, where it would make sense without blocking the opportunity to develop these remedies and keep viable products coming that will help people. And then public health can also play a really important role in bridging this platform with regulatory authorities, for example, approval processes, for example, pricing strategies, for example, patenting and intellectual property issues. So these are all extremely complex issues, but in this current world, again, I'm not really articulating my own philosophy, but for example, we have a patent discussion right now, and I don't really think, I cannot see that just by removing the intellectual property protection, you can address distribution problem. This, to me, it feels a little bit naive. But if we had a more thoughtful discussion, and I'm not really seeing a lot of public health engagement in this intellectual property debate, then perhaps it's possible to develop more creative models that will enable. India is a great example. Ashish, India is the world's greatest vaccine developer. India, if you start turning its gears, in a couple of months, it can produce all the vaccines that it needs. So why can't we enable this? But this is not really only a limitation of property, intellectual property, it's supply chain and etc. There are many, many issues. So that's why I'm saying having a foot in industry and really not alienating the intellectual horsepower in public health from the discovery process and translational process would be very useful.
Yeah, it is interesting, right, that to understand that the things that prevent us from making billions of doses of these vaccines, intellectual property may or may not be a part of that conversation. But the real issue is understanding production, supply chain, technology transfer. There's a whole set of issues that we often in public health have not wanted to engage in. I totally agree with that. I want to come back actually to a topic I was going to go down, and then I got a bit distracted with what was a really good question, which was to tie together the work on metabolic disease, metabolic conditions with the pandemic. So there are many things that drove poor health outcomes if you were infected with SARS-CoV-2. But it seems to me that one of the biggest, not the biggest, was the presence of metabolic disorders. The people who, and even age, like we never really have understood why age, except that there's something about the kind of immunologic and metabolic milieu of older people that maybe sets them up for worse outcomes. But no doubt about it, obesity, diabetes, other metabolic disorders had a profound effect on poor health outcomes. And I wondered if you could help us understand why that is. And a related question, Gökhan, and you might be going down this path, but it's really important in my mind, is what is the relationship between metabolic disorders and inflammation? Or because the issue in my mind is that we have this mental model of like, they're inflammatory diseases and then they're non-inflammatory diseases. And inflammatory diseases are infections and autoimmune diseases. And then there's the non-inflammatory stuff like diabetes and hypertension and coronary artery disease. But so much of your work has really questioned that paradigm. So if you could talk about that paradigm, but then also talk about it vis-a-vis the pandemic, that'd be really helpful.
Yeah, sure. Maybe it's good to remind the audience that I am not an immunologist or a vaccinologist, and so I am only really extremely intrigued by the both human cost, public health implications, and the mechanisms that might underlie this extremely complex viral infection. And this is actually what really compelled me to think more and actually even do some small activities related to COVID. I mean, what you say is true, particularly, for example, obesity is a big determinant of the severity of disease and mortality of the disease. And I mean, there are even people who speculate, and I somewhat agree that, for example, had we solved the metabolic disease problem, I mean, COVID would have been a much lighter problem to deal with in the world today. And this makes sense to me, I mean, looking at the numbers. So
can I ask you a different question then for a second? If this were 50 years ago, when we had a lot less obesity and a lot less diabetes, and COVID had hit 50 years ago, would the world have done better?
It's possible. I mean, of course, we did have pandemics before obesity and metabolic disease were this widespread, and their toll was also extremely heavy. But of course, in those days, we had huge disadvantages in terms of sanitation, medication, medical care, intensive care, and so on. So none of such things exist. So it's really difficult to compare the death toll. But I think that the impact of the pandemic would be severe, but the death toll, my guess is, would be much less.
Wow.
But this is, of course, very difficult to calculate.
Sure. So help us understand why. What's the connection? What's between metabolic disorder? What's your best guess? I understand you're not an immunologist, but help us understand what the connection is between metabolic disorders. We see it in obesity, diabetes, but what's your best mechanistic understanding of what's going on?
Yeah, so I mean, the short answer to that is there's really no understanding of the mechanism, but I can speculate on a few things, and maybe I can connect to aging, because aging is a natural risk factor for all of the metabolic diseases that we talk about. So in that sense, you can think obesity as an accelerated form of aging. So the mechanistic basis, I think, relates to aging, in my guess, would have a great overlap with the risk factors with obesity. And why obesity? So I can give, I mean, several lines of evidence. One is, yes, I mean, unlike what we thought 25 years ago, essentially all of the metabolic clusters, to a varying degree, emerge from pathologies at the intersection of immune response and metabolic homeostasis. So this is a two-directional relationship. So the metabolic state of an immune effector cell, whether it's a T cell or a macrophage, is greatly influenced by the metabolic environment internally and externally that it lives in. So the energy and carbon sources can actually determine the effectiveness of the immune response. And immune response itself, when it is not mounted properly or mounted and resolved properly, it is a universal risk for metabolic deterioration. So there is a two-way relationship between immune response and metabolism, and this relationship is heavily disturbed in obesity. There are ways, there's an inflammatory base that exists during the course of obesity. This is a chronic inflammation, but some parts of immune response does not really operate very well. There are some very awkward forms of immune defects associated with obesity. So this is one possibility. The second one is maybe a less recognized, but if you think about airway disease, right now, in terms of critical mass, one of the biggest risk factors for pulmonary problems is obesity. So obesity itself already disturbs the respiratory capacity of individuals. And this is very different than, for example, asthma. None of the classic asthma treatments actually work in obese individuals that suffer from airway disease. And then on top of that, there is also physical constraints that is introduced by obesity on the pulmonary system. So pulmonary system becomes especially vulnerable to these sort of infectious diseases. And we knew this before, but it wasn't really in the radar, high up in the radar. I mean, we saw this during SARS, we saw this during MERS. It's known from influenza that there is a challenge there, but somehow it also escaped me, to tell you the truth. I didn't think too much about it in terms of infectious context until COVID-19 came.
It's really interesting, right? So what you're saying is, and tell me if this is right, that the immune system and the kind of is really shaped by the metabolic milieu, which has this tendency of having a very profound effect. What's interesting about that, of course, there's so many, but one of them is for people who work on diabetes, who work on obesity, that the downstream benefits of that, of reducing obesity, improving diabetes, is all of the ways in which become more capable and have more, potentially more effective response to infectious diseases. And the pulmonary thing I think is really interesting. And I'm going to come back to another issue, but I've always assumed it was just a primarily mechanical issue. You know, you're obese, you don't have, but what I'm hearing from you, and certainly sounds like there's some evidence, scientific evidence to suggest that it goes beyond the kind of mechanical constraints that obesity puts on individuals.
Yeah, that's for sure. Yes, that's for sure. And that's a huge, for example, unmet need for those very high number of individuals suffering from this problem.
Yeah, yeah. So one of the things, now I want to just shift to talking a little bit about thinking about the future, and let's spend the next 10, 15 minutes just talking about that as we wrap up. So one of the things emerging from this pandemic is this model, this mental sort of, this notion that we are going to now invest a lot more in infectious diseases. And I'm game for that. I think that's a good idea. You will not hear me say otherwise. But what I'm hearing you say is do that. Don't not do that. Mm-hmm. But connect it to this other broader theme that has been developing over the last 50 years, which is this incredible burden of metabolic disorders that has been just below the surface, that is really starting to surface, because these two things are really interrelated. Mm-hmm. Is that fair? And how would you, and if you were advising NIH, which I'm sure you are in various capacities, how do you combine these two areas of work?
Yeah, so I think this is a very fair description, Ashish, and thank you for articulating it so well. And yeah, so I mean, my thinking is I see, you know, health and disease as a negotiation between what you're exposed to and what your infrastructure allows you to do. So if you win this negotiation, you establish equilibrium and then you remain healthy. If you cannot adapt or maladapt or lose this negotiation, you'll develop disease. So then, I mean, so this is one way of seeing really biology at the center of things. And then exposure, for example, one exposure you can define as your metabolic and dietary exposures, both internal and external. And on the other hand, the microbial or infectious exposures, again, internal, or external. So this axis is fundamental to many, many big public health problems. And it's a good choice. It's not the only one. For example, you can also describe ecological environment as the input on your biology and social environment as the input into your biology. You can also choose these axes and then investigate how they interface with biology and mechanisms. So this is one model, but this sort of thinking I think allows to maybe reframing public health. So really focus on how does human biology and all the tools, bells and whistles that it has, really respond to intrinsic and extrinsic stresses and inputs. So this is ultimate intersection of what regulates health or what really creates disease.
And let me ask this, which is, does that need to all sit within a school of public health, that entire body of work, or do you see greater collaborations between, and I'm not trying to be so simplistic as to think about the public health school versus the medical school, but do you see this as like part of the bridge between medicine and public health, or do you see this as all squarely within public health, or is that not even the right way to ask the question?
Yeah, I mean, I think the part that I like from what you said is the bridge. And so a bridge needs to have two sides for it to function. And so if there cannot be a bridge if this is all outside of your domain. And in order for information technology, understanding, advancements to really cross that bridge, you have to build that bridge. And one of those legs really need to reside in public health. I mean, in my way, I cannot find a better way of describing how one can really take advantage of incredibly exciting things that are happening. So it doesn't have to sit all in public health. Actually, no scientific question can be resolved in one domain anymore. And so, but the bridge, the parts of the bridge and the conversation and the exchanges really need to happen in multiple places. And in order to be able to do that, you need to have some critical mass situated right in the heart of the action. This, I cannot emphasize how critical is this to really recognize the opportunities. And Ashish, this may not be really only limited to biology. I mean, if you think about it, I mean, one of the basic pillars of public health is epidemiology and biostats. But I mean, this may also be overshadowed by, for example, incredible computational power now coming into play and transforming biology. There is artificial intelligence, machine learning, incredible computational biology. So these disciplines maybe reside somewhere else in engineering schools or other places. So these, it's a choice. I mean, you can choose one which is suitable for your environment. And of course, the most logical one is to really frame between medical school or basic science departments and your intrinsic capacity. And within the school also, I mean, even inside schools, I don't know how it is in your school, but the communication is not great sometimes between departments, between disciplines.
Yeah, no, that intellectual siloing is rampant at every institution. Actually, of all the things that I have noticed, I would say that intellectual siloing is less here, interestingly, than my former institution, which I love dearly, where you're still at, which is Harvard. But intellectual siloing is very, very easy to do because disciplines like naturally to fall under those silos. I'm going to ask you two more questions, and they're both a little bit more personal, a little bit less about the science and a little bit more about the scientist in you. And the first question is something I think a lot about for myself, and I would love your reflections on the importance of being wrong, the importance of making hypotheses that turn out not to be true, to making guesses about how something works and turns out those were wrong, how you manage them, how you deal with them, how you learn from them, why you think they're valuable. Because you've talked to me about this at one point years ago, and I found it really compelling, and I no way can I do it justice. So I'm going to ask you, why is it so important to be wrong? And how wrong should we be and how often?
Yes, so unlike immunology and vaccinology, I have great expertise in this area, Ashish. Yeah, so it is hard. I have to admit that. But I think one thing about science and scholarship and the problems that we deal with, and I actually tell this to my students and fellows all the time, that we think we are all smart and brilliant. And we are, of course, very good in justifying that our thoughts are superior to anything else out there. But the biology, for example, is so much more creative and complex than we could ever really imagine and postulate and hypothesize. So in that setting, and this is, of course, my personal experience also, if you really start loving your hypotheses and ideas too much, it really prevents you from making any discovery that's exciting or groundbreaking. And it's only when one matures a little bit, and I wouldn't even say accepting being wrong, but I think what's necessary is that you should be enjoying being wrong. And because every time you're wrong, that means you're in a path to discover something more interesting than limitations of your mind. And so and the second is, of course, being wrong is also a good incentive to be more tolerant of different ideas and disagreements, which is also a fundamental element of finding the truth. So if really our ultimate goal is finding the truth, I feel for a scientist or an aspiring scientist, talking to younger students, for example, it is really perfectly fine to be wrong. It's actually, if you learn it fast enough, you'll be more successful. And so in terms of how often we should be allowed to do this, this really touches my heart, Ashish, but even from very early stages of education, our system really does not allow people to make mistakes. The cost of mistakes are very high, even in elementary school, in middle school, in college. And so achievement is all by this performance criteria, predetermined criteria that eliminates people who really tend to navigate into different directions. So this is a very fundamental problem, and we really need to resolve it. And it has tremendous reflections in the current operational system of academia, which I feel like it may be on its last leg within the current model of performance management, progress, success, etc. So some of the things that we discussed will probably really require some visionary leaders in academia to really think about the formation of their structures in higher education, funding and promotion and rewards and so on. So for a scientist, really, just like in elementary school, if you're expelled from elementary school, that leaves it, tremendous scar that is very difficult to make up for in later life. Same for an academician. If you cannot do your research, it takes you out of the path and away from your dreams and potential accomplishments. So we have to change that system as well, or think about it at least.
And just, if you don't mind building on this, tell me about how you see the role of diversity of experience and backgrounds as a defense against getting stuff too wrong, and as a defense against falling too much in love with our own ideas.
Yeah, that is one of the really greatest gifts that science and academic life actually gives us. So if you ask me what is your greatest joy in doing science, I will say the kind of people that it's uniting force, the kind of people that we are able to work with from every different culture, religion, life choice. So none of this really, of course, there are some people who may have such ideas in science, but by and large, it's a tremendous uniting force, and it's a constant auditing of your own biases, whether these are, personal biases, professional biases, scientific biases. So diversity of thought is of course shaped by diversity of experiences, diversity of cultures, and the more we integrate that into our academic life, the more enjoyable and exciting and creative it would be. There's no doubt about that.
Yeah. Yeah, I'm struck by, I had a chance recently, I know I talked to you about this, to have a conversation with the two German scientists of Turkish origin who built the BioNTech Pfizer vaccine. And they very much talked about their immigrant experience and having a team of immigrants as people who have dealt with adversity, have withstood those challenges, look at science and the adversity that science throws at you in a very different way, and have come to value the differences in experience. Let me just finish by asking if you have, there are a lot of students and young faculty who join these seminar series. And so if you have advice for them as people are kind of early in their careers, one of them may be willing to be wrong and surround yourself with academic leaders who are tolerant of you being wrong. But what else? What else? And I, by the way, we talk about this a lot in my team, that I say to folks, if you're never wrong, I mean, it's a huge problem. We need people to try new stuff and push the boundaries. But advice for junior people whose careers are still early in their academic life. What do you think are the important things that they should be thinking about and emphasizing?
Yeah, as I said, I mean, this is one thing that they shouldn't be so scared or maybe even rebel against this idea that you need to be always right and always do the right, accepted, conformist view of life. The second is, I think it is tempting to dominate your environment in our culture. So, but I think a smarter approach is really make sure you're not the smartest person in whatever environment you're existing. It may sound like a silly remark, but it has huge implications on your control of your ego, control of acceptance of creativity that comes from other people and different ideas. So this, for example, one should be very comfortable to be challenged and to be rejected in a civilized and scholarly manner, not in a dogmatic and confrontational manner. But there is a great joy not to be the smartest person, and this is actually especially true for leaders. If you're leading your lab, I mean, I shouldn't be the smartest person in my lab, otherwise my lab will not be creative. Or I mean, you shouldn't be the smartest scholar in your school, because then your school will be just limited with your capacity. So this would be, I think, my second advice. And the third is really biased, because I did come from medicine and then switch to public health. I think whatever you do, if that allows you to experience human touch and humans in their worst condition and best conditions, then they are, I mean, when you're in medicine, the status of the individual, whether it's financial, political, whatever, doesn't really matter. You deal with the naked person. And that is a very humbling experience. And even if you don't practice these things, and if you do it in public health, I mean, if you go to places, you can actually do this in a massive scale. So experiencing that in real life is a very humbling experience. And it's an extremely enriching experience. Even if you don't end up doing that, yep, that is never a wasted time. For example, I didn't practice medicine for 20 years. But I still cherish what I learned in medical school. That defines almost everything I do. And same will be, I mean, if your public health experiences in the field, in contact with people, are extremely enriching. So this will somehow, getting this from one dimension or another would be very, very useful and valuable.
Yeah, and thank you for that. And that third point of really, it doesn't have to be in the practice of medicine, it can be in the practice of public health, but being real and grounded in people's realities and in their lives is hugely important. And then, of course, I agree. I mean, the line I've often heard is, if you're the smartest person in the room, you need to go to a different room. It's really hard to to really be creative and push the envelope if you're the smartest person around. And then the first lesson around not being fearful of mistakes, and in fact using that as moments to broaden your own thinking. I want to just say thank you, Gökhan. This was lovely. This was wonderful and insightful, and reminder of this very fluid world between what is basic science, what is medicine, what is public health. And that in fact, the greatest successes of public health often come from medicine and basic science. And then some of the greatest successes in medicine come from public health interventions that change the entire landscape of medicine or basic science. So these are three fields that belong together, and fewer divisions within them get us all further ahead. And there really is no one I can think of who's done a better job of bridging all three. So thank you for coming today. This was wonderful and lovely, and just I learned a lot. And stay well, stay safe. And to all of you who came, I'm sorry, there were a couple of questions I didn't get to, but thank you all for participating today. It was terrific.
Yeah, thank you. It's my pleasure. Thank you for having me.
Bye-bye.